Hi, thank you for viewing this nurse and provider training for the Reverse the Cycle program at Hazard and Whitesburg ARH. Today, I will review with you the Reverse the Cycle model and workflow at your hospital. I'll help you understand the role of peer recovery coaches, the screening tool nurses should be using to identify patients with high risk substance use, explain the role that nurses play as it relates to conducting the Clinical Opioid Withdrawal Scale for patients that are being considered for buprenorphine administration in the emergency department, and explain the provider's role as it relates to evaluating patients' clinical appropriateness to receive an initial dose of buprenorphine in the emergency department. To give a little background about why Mosaic is supporting ARH, the Reverse the Cycle model is a comprehensive substance use response program that's designed to work in an emergency department. It has been implemented in over 50 hospitals across the nation, including Highlands ARH and Harlan ARH. The Reverse the Cycle program was first implemented at Hazard and Whitesburg back in September 2020. Since then, there have been some enhancements to the program, which I will be reviewing with you in today's training. The Reverse the Cycle model includes 3 components that are focused on capturing the most at-risk substance-using patients that present to your emergency department. It includes nurses administering a universal screening to identify these patients. After these at-risk patients are identified, there will be staff available to provide an intervention. These staff are called peer recovery coaches, and they identify as individuals who are in long-term recovery. They will address the needs of a variety of substance-using patients, including those who are overdose survivors. They will also work closely with you to identify patients that are eligible to receive an initial dose of buprenorphine in the emergency department, along with a referral to treatment. In this training, I'll walk you through each of these components of the program so that you clearly understand your role within the Reverse the Cycle protocol. As we look at substance use, we recognize that it is a national public health crisis. To understand the importance of having a model like Reverse the Cycle in your emergency department, I'll provide some context and share data on substance use nationally and locally in Kentucky. In 2020, there were over 100,000 drug overdose deaths reported. 2/3 of those deaths involved fentanyl or another synthetic opioid. Kentucky overdose deaths rose by nearly 50% in 2020. That's close to 2,000 fatalities. According to the National Institute for Healthcare Management, in the previous year, 2020, there were over 67,000 opioid-related deaths. There has been more than 1,000% increase in opioid overdose deaths. As the rates of death grew, the minutes between deaths fell correspondingly. By 2020, one person was dying of an opioid overdose every 7.75 minutes. And nearly 75% of drug overdose deaths in 2020 involved an opioid. In the last 6 years, we've seen spikes in the number of drug overdose deaths amongst Kentucky residents by certain drug types. With special attention given to fentanyl and methamphetamine, we see fentanyl deaths rose by 396 and methamphetamines rose by 199. There hasn't been too significant of a variation in rates for prescription opioids, benzodiazepines, or cocaine. Those have remained pretty steady. And lastly, heroin, we have seen a decline in these rates. Now, you might be wondering what can be done to confront this crisis. I'll now move on to providing an overview of how Reverse the Cycle addresses the national substance abuse epidemic we're facing. The Reverse the Cycle model is a comprehensive substance use response program. There are 3 components of this program. One is universal screening and peer intervention, the Overdose Survivors Outreach Program known as OSOP, and then there's the initiation of medications for opioid use disorder in the emergency department. I'll now walk you through the workflow for the Reverse the Cycle program in your emergency department. The Reverse the Cycle protocol has been approved at a system level by leadership across ARH. This protocol includes having all emergency department patients ages 18 and older being screened by their nurse during triage. The screening tools are located in Meditech and include a series of questions used to determine a patient's risky substance use as it relates to alcohol, prescription drug misuse, and illicit drug use. If a patient's score is a 7 or greater on the Audit C, which is a tool used to determine alcohol use, and/or answers yes to either of the 2 drug questions asking about a patient's prescription or illicit drug use, they will be considered a positive screen. The screening tool that should be used to identify patients with high-risk substance use is called the Adult Expert Screening. The screening may be accessed in two different areas, either in the triage section of the patient's chart or within the patient's work list. Again, this is a screening that will be completed by nurses during triage with every patient over the age of 18. Here you see a screenshot of the first half of the screening tool. The first half includes exclusion criteria. Patients can be excluded from either answering the questions or participating in the screening due to their presentation or chief complaint. Some criteria will automatically trigger a peer consult. These criteria include intoxication, suspected opioid overdose, and suspected overdose. As you can imagine, these patients may not be able to adequately participate in answering all the screening questions because of their presentation. So by clicking this criteria, it allows for the patient to still be identified and receive a peer intervention. Then there's the provider request criteria, which should be selected for patients that did not respond affirmatively to the audit C or drug questions, but the patient's nurse or provider suspects the patient uses substances and will need a peer intervention. There are other exclusion criteria that will exclude the patient from participating in the screening fully. Those include patients under the age of 18, patients with an acute psychiatric illness, patients that are critically ill, nonverbal, or in police custody. If the patient does not meet any exclusion criteria, nursing should select none and proceed with asking the rest of the screening questions. Here you see displayed a screenshot of the full screening. It begins with the exclusion criteria, which we just covered. Next up are the audit C questions. These are 3 questions focused on understanding patients' risk level as it relates to alcohol consumption. These questions should be read exactly as they're written. This is a validated screening tool, so if there's any deviation in language when these questions are being asked, it invalidates the screening tool. So nursing, please make sure you're asking the questions as they are written. If patients give a vague response to your questions, please read off each response option to the patient and ask them to share with you, out of the responses that you read, which one matches best with their alcohol intake. Patients with audit C scores between 7 to 12 will receive a peer intervention. After you've asked the audit C questions, you should proceed to ask the 2 drug questions, which should also be read to the patient exactly as they are written. If a patient responds yes to either question, please ask what substances they use and enter their response. A yes response to either of these questions is considered a positive screen, and the patient will receive a peer intervention. There are 7 different ways a patient can screen positive on this screening tool. To recap, these include meeting the following exclusion criteria: intoxication, suspected opioid overdose, or provider request, having an audit C score between 7 to 12, and responding yes to either of the 2 drug questions. Before I move on to review the other 2 components of the Reverse the Cycle program, I want to take a second to explain the provider request exclusion criteria. This criteria should be selected if a patient will not answer the screening questions or the nurse or provider suspect that the patient may use or drink at risky levels. This criteria may also be used if a patient screens negative on the adult expert screening and the nurse or provider suspects the patient may use drugs or drink at risky levels. Providers, please tell your nurse that this criteria should be entered if you would like a patient to receive a peer consult if they do not answer or screen positive to the adult expert screening questions that is initially asked by the nurse during triage. The foundation of this program and the individuals who will be working with substance using patients in the emergency department are called peer recovery coaches. Peer recovery coaches are individuals in long-term recovery from substance use disorders that are trained in motivational interviewing and other skills to use their lived experience to help patients that are in active addiction. These individuals will have a conversation with patients who screen positive for risky alcohol or drug use and make referrals to treatment as appropriate. One of the primary enhancements that was made to the Reverse the Cycle program at Hazard and Whitesburg includes the implementation of a shared peer model across the Kentucky River region. This means there will be a total of 5 peer recovery coaches that will provide support across the 3 hospitals. If a peer is not on shift at your hospital and there's a patient who screens positive on the adult expert screening, a telehealth intervention will occur with a peer recovery coach who is seated at one of the other hospitals. This could be Hazard, Whitesburg, or Mary Breckinridge. There have been 4 peers designated to provide support to patients in the emergency department and 1 peer designated to provide support specifically to patients that are identified as an overdose. There have been clinical staff designated at each of these hospitals who will be responsible for working with your hospital staff to assist with setting up the technology for the peer to complete a telehealth intervention with a patient. The staff designated at Hazard is the clinical nurse manager on shift, and the staff designated at Whitesburg is whoever the patient's assigned nurse is. There will be peer coverage 7 days a week between the hours of 8 a.m. and 10:30 p.m. with a combination of in-person peer support and telehealth peer support. The second component of the program is the Overdose Survivors Outreach Program. This is also known as the OSOP program. This component of the program will help address the overdoses in Leslie, Perry, and Letcher County. The OSOP coach will provide community outreach to these survivors. The support that will be offered to patients is really focused on working with the patient to prevent a subsequent overdose. The OSOP coach will have weekly and sometimes even daily contact with patients to support their recovery. Once the peer who's working in the emergency department has spoken with the patient, if they have reported any opioid use, we want to consider them for a dose of buprenorphine in the emergency department if they're motivated to go to treatment. Mosaic has implemented reverse the cycle in hospitals across the nation since 2014, and it's been about 7 years since we have been working with hospitals to administer a dose of buprenorphine to patients who are opioid using. Next up, I'm going to share with you an overview of the part of the program that involves patients receiving an initial dose in the emergency department. There's a great deal of research and science that supports medication-assisted treatment for opioid use disorders does save lives. I want to share with you some of that research. It's been found that medication like buprenorphine is estimated to reduce mortality by up to 50%. It's been linked to reduced risk of overdose deaths, and the risk of opioid overdose death declines immediately when patients with opioid use disorders are initiated with buprenorphine treatment. Furthermore, buprenorphine is associated with improved social functioning, decreased IV drug use, reduced HIV transmission, HIV diagnosis, and better quality of life overall. In terms of how buprenorphine works, as you know, there is a ceiling effect, so the patient cannot get high. There's also the naloxone present that blocks the opiate effect if injected. You may be familiar with the D'Onofrio study out of Yale, where they similarly, out of an emergency department, had 3 study groups. One was initiated with buprenorphine in a 3-day prescription with a referral to a primary care provider with continued maintenance and therapy. One group received a brief intervention and then got a referral to treatment with no medication, and the third group received a simple referral to treatment. And what you can see in terms of engagement at treatment in 30 days was their retention and any self-reported illicit opiate use, as well as their toxicology report for opiate use. The group who received buprenorphine in the emergency department with that coordinated link and bridge to care did better across all 3 components. They were retained in treatment at a rate of 78%, much higher than the other 2 groups. And their self-reported illicit opiate use was fewer days, and their urine toxicology negative was at a higher rate than the other 2 groups as well. When we think about practitioners using narcotics to treat opiate addiction, there's a separate registration or waiver needed. The Drug Enforcement Administration has an exception to the registration requirement, which is known as the 3-day rule, which allows practitioners who are not a waiver provider to administer but not prescribe narcotic drugs to patients for the purpose of relieving their acute withdrawal symptoms while a patient's referral to treatment is being arranged. Under the exception, ED physicians are permitted to administer buprenorphine to patients for no more than 72 hours. If there are any patients that present to the emergency department on, say, a Friday evening and cannot get into treatment the following day, providers are permitted to provide patients with bridge dosing until they are able to attend their appointment on the next business day. The patient must return to the emergency department each day to receive their dose. When we think about initiating medication in the emergency department, we know that patients who begin or are already experiencing withdrawal when they are in the emergency department could receive a combination tablet of buprenorphine and naloxone to feel better, allowing them to participate more actively in their health care. When patients feel better, which happens almost immediately after receiving the dose, they can understand their discharge instructions better. They're less likely to leave AMA out of fear of getting sicker. And when they feel better, they're less likely to use an illicit substance overnight before they go to treatment the following day. We also know when patients receive a dose and avoid illicit use, they're more likely to engage in treatment within 24 hours. And when we look across our hospital data, we know that the patients who received a dose of buprenorphine in the emergency department show up at a rate of 65 to 70%. So there's a very high likelihood that they're going to enter treatment the following day. The way this component works is the patient has already screened positive and has received a brief intervention from the peer recovery coach. Through that conversation, the peer has to determine that the patient is motivated for treatment and is willing to go to care the next day. Those are really the two components the peer is figuring out, that the patient wants to go to treatment and they're willing to go the following day or same day. At that point, the peer recovery coach is going to talk to the provider to let them know the patient is motivated, opioid using, and should be considered to receive a dose of buprenorphine in the emergency department. The provider is then going to assess the patient for any exclusion criteria, which I will review with you as a part of the ARH protocol. And then the provider will order the clinical opiate withdrawal scale. The nurse is going to conduct the clinical opiate withdrawal scale, which does exist in Meditech. If the score on the clinical opiate withdrawal scale is 8 or greater, then the provider will order an 8 milligram dose of buprenorphine. The nurse will then administer and observe the patient is taking the medication. And meanwhile, the peer recovery coach is working to coordinate the patient's care for the following day. I'll go into this in more detail, but those are what we call fast track providers in the community who we have developed protocols with so that coaches can refer patients to them either the same day or next day for continued induction and maintenance. When a peer has recommended the patient be considered for a dose of buprenorphine, there are some exclusionary and cautionary criteria the provider should consider. So we don't want any patients to be on any long-acting opioids for pain, if there's any evidence of liver disease, or if the patient's in any acute psychiatric distress and unable to consent to treatment, then we would not want to consider them. Or if the patient reports an allergy to buprenorphine and naloxone. We also want providers to proceed with caution, but not exclude the patient entirely if there's any prescribed or illicit benzodiazepine use or if the patient's pregnant. Neither of these disqualifies the patient, but we do want to make sure you feel confident dosing the patient and proceeding from there. Here I've included a screenshot of the MAT order set or the MOUD order set. When the patient notifies the provider that, when a peer notifies the provider that a patient should be considered for a dose, there is also a trigger that notifies you it is time to consider the patient for any exclusionary or cautionary criteria, and that there is a MOUD order set that you will be able to follow in Meditech. You'll see it includes the exclusion and cautionary criteria at the top. It also includes nursing orders for the clinical opiate withdrawal scale, the medication, which, as mentioned, is an 8 milligram dose of buprenorphine, and the consult for the peer recovery coach. So here's the first screenshot and the second screenshot. As part of the MOUD initiation protocol, it's also important to make sure that the patient meets the DSM-5 criteria for a substance use disorder, which is outlined here. When giving patients an 8 milligram dose of buprenorphine, we have not seen a high rate of precipitated withdrawal occur, but we do know withdrawal is more likely to occur when there is a level of physical dependence that is high, or there has been a short time since the patient's last opiate use, or if that initial dose of buprenorphine is too high. So again, that's why we do the clinical opiate withdrawal scale, to make sure they're far enough into withdrawal that we might prevent precipitated withdrawal. And we want to look at the exclusionary and cautionary criteria. If the patient happens to go into precipitated withdrawal after you've administered or the nurse has administered that first dose, we recommend that you give a 4 milligram dose to the patient in addition, so that we can prevent precipitated withdrawal. Displayed here is a screenshot of the clinical opiate withdrawal scale. As I mentioned, the nursing team will be administering the clinical opiate withdrawal scale with patients. This is a series of 11 questions that the patient can score on, and any score of 8 or higher makes the patient eligible to receive a dose of buprenorphine. While the provider and nurse are working on administering the patient's buprenorphine, the peer recovery coach is arranging for the patient to be referred to a fast track provider. Fast track providers are an existing network of community providers Mosaic has worked with that have committed to receiving patients from your emergency department who've been dosed. These providers are ready and willing to accept patients from the emergency department the same day or next day for continued maintenance. Each fast track provider has a unique protocol the peers will follow to schedule patients an appointment. The peer recovery coach will not recommend a patient to the provider to be considered for a dose unless the patient has confirmed they will attend treatment and there's likely an available appointment the following day. A few confirmed fast track providers for your hospital include the ARC, MCHC, Sparrow Health, and Behavioral Health Group. The Reverse the Cycle program will be going live with these new enhancements on August 17th. Tiffany Latham, who is a senior behavioral health consultant with the Mosaic Group, is the primary consultant working with ARH to support this program. She'll be providing in-person and remote technical assistance to support the peer team and you throughout the process. Her phone number and email address are listed here. She'll be checking in with the peer team almost daily and working with the planning team to continue with the supportive implementation. Thank you so much for your time. Please reach out to Tiffany if you have any questions. Have a great day.